Hello, thank you. I'm very honoured to be here. I'm one of the physios among us, and I did my PhD in biomechanics, so I'm hoping I'm kind of qualified to talk. Thank you. So I'm talking about kind of leg length differences, in particular kind of the use of pressure plate. This is Stonehenge. It's my local kind of running route. And there is a slight stone theme. I'm a bit of a hugger, kind of secretly. So what's it all about and why is it important? Well, leg length differences have been related to patellofemoral pain, knee osteoarthritis. Addressing leg length differences has been related to improving back pain. And significant relationships have been found between leg length difference and gait deviations, but it's not completely clear. There's a recent paper by Hispaniol which showed that differences in leg length wasn't actually related to prospective injuries. So we'll see how that kind of develops. So what's opinion and kind of what's fact? So most studies that have been conducted to kind of looking at the effect of leg length differences on gait are done by inducing a leg length difference. So there is evidence that differences more than a centimetre show gait deviations, and that the larger the leg length difference, the larger the deviations you find. And the typical deviations that we probably all know about are that the shorter leg will show more rear foot, so plantar flexion and inversion, and less hip adduction. The long leg will show more dorsiflexion, eversion, and hip adduction. The long leg will typically show increased hip flexion and knee flexion, and there are increased hip flexion and eversion moments in the shorter leg in late stance. But we have to remember that people are people, and not everybody will conform kind of to the expected norm. So I would really encourage you, when you're looking at measuring and evaluating leg length differences, that you need to be open-minded, you need to be objective, and you need to not make the kind of the story fit, kind of fit the picture. So we move on to measurement. So the typical measurements, I will start obviously kind of with the patient in standing, and we'll look at the usuals kind of shoulder height and hip height and skin folds and pelvic obliquity. We'll look at knee creases. That doesn't come out very well, sorry. And then I will also look at their squat function to look at symmetry. I also find it really useful to look at a side flexion, in particular kind of taking the arm over the head. And you will often see that short leg, kind of the heel popping up kind of quicker. Not always because of a true leg length difference. It can be more for a kind of a functional or apparent, but it's always worth kind of looking at. After standing and functional movements, look into supine. So again, I will kind of get somebody to bridge to make sure that the pelvis is kind of level before doing the Alice test. And then with the legs straight, I would always come onto a long sitting just to check for any kind of pelvic shunt or SIJ problems. Once we've done that, then you'll measure your usual kind of true and apparent and record that. Not rely on your memory kind of to the end of the day. I would also suggest that you know your own intra-relator reliability on measuring leg length. So it's a really good idea to kind of sit down in the department or wherever you work and work out kind of your own reliability. So for me, I have to do it with only my right eye, because if I use two eyes, then I get a consistent bias to measuring the left ear longer just because of my method. So it's definitely worth kind of trying with both eyes and seeing how you go. So then usually, if there's a suspicion, I will then kind of measure them static on the pressure plate. I don't with everybody, but I do find it really useful. So here we can look at left to right differences, we can look at rear foot to forefoot differences, and within foot you can look at medial to lateral. I personally think that, and it's anecdotal, but people who show kind of obvious distal compensations for a leg length difference are more likely to show a 50-50 distribution of weight. Those who don't show as many distal compensatory strategies tend to be outside of tend to be kind of outside of the normal. I consider normal to be kind of 5% either way, and this is Ben, my husband, who we saw on the previous slide, who shows a left foot slightly anteriorly kind of positioned compared to the right, and his left to right ratios are 44 to 56. And his left leg measures about 2 centimetres shorter. So his right dominant leg is just outside of my kind of my 5% each way kind of comfort zone. So I'd definitely be kind of, you know, even if I hadn't already measured the leg, I'd definitely be suspicious and wanting to look at the kind of the gait on this patient or my husband. So moving on to dynamic analysis. So again, kind of walking on the pressure plate, I will normally do this at their comfortable walking speed and barefoot, and then I will often do it fast walking as well. And again, you often see differences between the kind of the two legs only really kicking in kind of when they go into a faster walk. I do sometimes use it for running, but not always, because in my population, they only ever really have to run with boots on. So, or trainers, never barefoot. So in terms of our kind of dynamic assessment, so these are both strides from Ben, the kind of the middle and the right. So we can use the pressure plate to look at kind of stride length, but in particular, you're more interested in the stance phase timings. So, so here on the bottom left, so on the bottom left, we've got the kind of the usual kind of breakdown, and the medial and the lateral kind of rear foot are really what we're particularly kind of interested in here. And actually in Ben, they're relatively symmetrical, and you can't see the kind of halfway, but the RS scan picks up the kind of the halfway stance. So, and that would generally be your marker for are they maintaining kind of rear foot pressure until that halfway. If you get really picky, actually, his left foot, he is kind of, you know, he has got kind of a slightly shortened kind of whole stance phase on the left compared to the right. That probably is a little bit picky. Probably wouldn't stand up to kind of rigorous research. And then moving forward, you look at your kind of typicals really. So your direction of travel, your whole kind of centre of pressure, kind of timings and location. And here we are kind of seeing a classic kind of shorter leg, high pressure on the kind of under the fifth, lateral low gear kind of propulsing left, and definite tendencies, particularly on that kind of far right stride. For increased kind of right compared to left kind of load through the first ray, and some evidence of functional hallux limitus on his right. Now, I really don't know how these are going to come out. I'm sorry. We'll just play them. So again, you can see kind of from the kind of the synchronized play of the kind of the pressure plate. Actually, he's got a two-phase kind of pronation going on his right, probably because of his really rigid plantar flex first ray. And on the left, clear kind of lateral pressure, low gear kind of propulsive style on his shorter left leg. We'd also match that obviously to our normal kind of visual gait analysis. So again, kind of looking at the shoulder heights, the hip heights, the trunk side flexion, pelvic obliquity. And here you can clearly kind of see his asymmetrical arm swing as well. In my corridor, I'm really sorry. I would obviously normally be on a treadmill. So now we're thinking, back to my stones, does it all add up? So you're really comparing your standing, your functional movements, your supine measurements with your static pressure plate, your dynamic pressure plate, and your own kind of visual gait analysis. And with Ben, do we think it's kind of clinically relevant? Yes, I think it probably is. He presents with a low back pain and Achilles, but not atypically. His Achilles pain is on his right, his longer leg. I have theories of that, which I'm happy to discuss kind of at later dates. So even the best of uprights kind of sometimes need a little work. The lesser known fact may be that Stonehenge was kind of semi-rebuilt in the 40s and 50s. And again, we got Ben walking. Sorry. So I think that's a video. So here we have kind of action. So this does relate to kind of what everyone else has kind of previously been told about. So we've done our subjective, usually. We've looked at lots of objective tests. We've analysed it. And now we've got a plan and we're going into action. So, so here I've added a 7 mil heel raise under his left. And again, you would decide whether you want to add that kind of rear foot or whether you want to add that whole foot. And I would always trial. I usually send people away for a week or 2 weeks kind of to trial that and make sure there aren't any adverse effects. Looking at whether our objective kind of measures change. So does symmetry improve? Does stride length improve? Does stride timings improve? And does the patient like it, most importantly? And if everything is positive, then we'll send them away. We'll get them to trial, get them to come back kind of in that 2-week kind of period and make that into as robust a solution as you kind of feel you need to. And conversely, if things don't add up or you think that actually it's really important, you know, it'd be better kind of argued to do that to address it kind of through kind of rehab, then again kind of either addressing it yourself or collaborating with your other healthcare professionals would be really important. So finally, my colleague Paul would have kind of proposed a very alternative solution of kind of walking on your hands if your leg length was a problem. Unfortunately, he was diagnosed with cancer last year and died just before Christmas. So I would like to dedicate my talk to him. And if anybody who knew him would like to support kind of his wife's fundraising for immunology research, then the link is there. Thank you very much.